Good evening, everybody. My name is Stephen Woolfolk. I'm the Director of Programming and Marketing at the Kansas City Public Library. And about 2 hours ago, I was at my doctor's office. And while I was sitting there in the waiting room, I was thinking about the event tonight because how could I not be thinking about the event tonight while I'm sitting in my doctor's waiting room? And more specifically, I was thinking about why there are so many people who are opposed to universal health care. And I'm not talking about the people who have reservations about universal health care. Certainly there are valid reasons why somebody might have concerns about the cost and the practicality of a single-payer system, although our guest tonight does a pretty good job of dispelling those concerns. I'm talking about the people who just don't want it, period. They don't want to talk about it, they don't want to think about it, they don't even want to hear about it. And I think there's a few reasons, but the big one that I figured out, or at least figured out a small part of it, is one, we lack empathy. And I think that many, perhaps even most Americans, are like me. They have insurance and they are relatively healthy. They go to the doctor once or twice a year, they spend $30 for a copay, they spend $15 at the pharmacy, they have insurance through their employers, so their premium's only $12, $13, $14 every 2 weeks. And I think that we'd all agree under that scenario, the current system is probably working just fine. But what they don't give much thought to is what might happen if they weren't in relatively good health. They don't pay attention to the deductibles and the co-insurance that would leave them with thousands of dollars in medical debt, even with insurance. They don't give much thought to the people who don't have as good of insurance through their employer. I have a very good employer. I have very good insurance for myself. My family, I pay 100% of. Some people aren't lucky enough to have even that. And we don't think enough about that single parent out there who doesn't get insurance through their employer, who might be paying upward of $700 every 2 weeks for insurance for themselves and their 2 kids. And I think that a lot of those people, when confronted with the data, they're willing to at least acknowledge that there is a problem. I think that we just need to spread that message of empathy, and nobody is doing that better than our guest tonight. Timothy Faust is the author of Health Justice Now, Single Payer, and What Comes Next. He discusses the what and how of a single-payer healthcare system, but where his passion really comes through is in making his case for the why we should have a single-payer system. He is spreading empathy from reader to reader and state to state. His passion for this subject really comes out when he talks, when he speaks. His passion really comes out in the book, which, by the way, is available for sale out in the lobby, courtesy of our friends for the library. I hope you'll check it out. I know Timothy's willing to sign copies when we're done tonight. He has worked as a data scientist in the healthcare industry. Before that, he enrolled people in the Affordable Care Act programs in Florida, Georgia, and Texas, where he saw both the shortcomings of the Affordable Care Act and the consequences of the Medicaid gap. The book, again, is Health Justice Now. Please welcome to the Kansas City Public Library, Timothy Faust.
Howdy, y'all. How's it going? Let me get the important thing out of the way first. Congratulations to Kansas City and the Kansas City Chiefs. I grew up in Green Bay, Wisconsin, it was better back then, under Brett Favre, and then, of course, Aaron Rodgers. So I've seen my share of greatest of all-time quarterbacking, but Mahomes has got something special, and it's real fun to watch him. And y'all did great out there, too. So thank you for giving me something to watch in 2 weekends. I want to say thank you to the Kansas City Public Library for having me out. I like Kansas City. The food is fantastic. The people are very friendly. The city's very pretty. And thank you to y'all for coming out. This is my first book, and frankly, I'm not really a writer by trade, but I'm very proud of it, and I hope you find it useful if you've read it. If you haven't read it, may I recommend you pick it up and read it. That's why we're here. But instead of reading right from the book and giving you 10 minutes on how Medicaid works, I want to talk about some of the themes within the book. It's not all happy, but you probably already knew that. There's a lot of bummers in American healthcare, and there's a lot of tears in this book, but I tried to line it with little glimmers of hope. right? Because there is a vision in this book of a better world in which we can be free from the crippling fear of the betrayals of our own bodies, where we can stand together free and safe in our own flesh. And frankly, I believe it. I believe we have the tools and resources to build this freedom. We just have to demand it. We got to demand it in opposition to the world that we have now, a world that is not natural, but created. And because it is created, it can be changed. But until it is changed, until we change it, ours is a birthright of continual exploitation. We are pumped for labor and drained of cash, and we suffer. And we are then punished for that suffering. We are punished for being hungry. We are punished for being sick. We are punished for being disabled. We are punished for being poor. We are punished for being black or brown, for being queer, for being pregnant, for being unlucky, for just being. And at the core of all that suffering and at the core of all that punishment sit two little truths. In America, sickness makes you poor and poorness makes you sick. So if you permit me, for the next half an hour, I want to talk about that relationship and how it's expressed through our healthcare and health finance models. I want to talk about three things: what we have, what we want, and what lies beyond. I want to talk about the overwhelming and numbing brutality of for-profit healthcare. I want to talk about the relatively benign structural changes that we demand instead. And then I want to talk about something bigger, a broader vision of a better world, the moral compulsion of health justice. That sound good? Fantastic. Thank you very much. Let's have some fun with the fundamentals of health policy. Nobody can afford to pay off all their own healthcare costs by themselves. Medical care is extremely expensive and always has been. But generally speaking, not a lot of folks need it at the same time. In a given year, 50% of national healthcare costs come from 5% of the population, a population which someday you will join. Right? Eventually your day of tragedy comes, and when it does, the medical costs will be enough to bury you. That's why we have the concept of insurance. Insurers pool together money from a lot of people to pay off medical costs for those who need it. And so the larger this pool of people, the wider it can spread costs, and the lower its per-person costs or per-person risk. In the US, we delegate the business of insurance to private insurance companies. Insurance companies charge us monthly premiums to build their risk pool. And like any company, their job is to make money. So if an insurer has too many folks who use their insurance plans to seek health care, or too few healthy people, or too many sick people, just one person with hemophilia, for example, can cost up to $1 million a year to insure, its per-person costs really increase. And so to compensate, it increases premiums. But when premiums go up, customers who can't afford them drop out. But sick people, people who are expensive to take care of, can't afford to drop out of their insurance plans because they need the insurance. And so you have a customer base that is per capita sicker and sicker, and thus more and more expensive per person, leading once again to higher premiums, leading into a sicker and sicker, more expensive customer base. It's this big, stupid Ouroboros of misery. Thus, an insurer wants as uneventful a risk pool as possible, or wants to find ways to kick out sick customers or to coerce them into leaving. Maybe it drops coverage for the drugs sick people need. Maybe it cuts off access to the doctors and the hospitals to treat the sickest patients. Maybe it does both. Usually it does both. Because insurance companies don't lose money when you get sick. Insurance companies lose money when you get sick and then use your insurance plan. And there's nothing they could do about it, even if they wanted to. Because if insurance companies were to offer the care people need where they need it, or if they were to offer it at rates sick people could afford, sick people would buy those insurance plans and use those insurance plans, and the insurance company would lose money, which is a pretty bad way to run a business. You know, at some point along the line, I wonder, what's even the point of blaming them? Blaming an insurance company for seeking profit, even though it hurts people, is like blaming a rabid dog for biting, or blaming a scorpion for stinging. This is just what companies do. And that's why healthcare doesn't belong in the hands of companies, because they just can't, they just won't do the right thing. Instead, they've turned our bodies and our health into commodities. And this commodification of healthcare reduces health to a financial transaction or an investment vehicle instead of a connection or a relationship between a person and their body and their doctors and their communities. That's perverted. We've mistaken the profit motives of corporations for healthcare. And the people who profit from that commodification have decided to shackle the well-being of children to whether or not their parents are lucky enough to have a benevolent employer. And even if they've got a union, instead of fighting for better wages and workplace safety, every year their parents got to negotiate for more and more expensive insurance, which can be stripped from them, as we saw in the UAW strikes. And so our children, our families, the people we love, are hostages to our employers. And if you ever try to organize against those employers, if you dare demand your fair share of the fruits of your labor, their bodies are held ransom. Our employers demand total domination in mind, body, and spirit, and they've used the tools of health finance to forge the manacles. That sucks. That's one side of the coin. But it gets worse, of course. It's too early in the talk for things not to get worse, because the costs of healthcare keep increasing. Most of these cost increases occur because hospital CEOs and pharmaceutical companies keep finding ways to charge more money for the same services or rack up fees for other services, and no private insurer can stop them. Here's how that shakes out. Fundamentally, in the US healthcare market, all prices are fake. They're just totally fake. Here's what I mean by that. In the US, the average inpatient procedure costs 40% more than the same procedure performed on the same patient when performed in France. The costs are high because the prices are high. Or take MRIs. Y'all know what MRIs are? MRIs are just big fancy tubes that print money. And in the US, an MRI scan costs 5 times more than the same machine scanning the same scan when scanned in Australia. But it gets even dumber closer to home. Sometimes MRI scans from the literal same machine in the literal same room in the literal same facility have a 7-fold cost variance for arbitrary reasons like what doctor is on staff, what time of day it is, or what insurance the patient has. Prices are totally fake. Over the course of the past decade, we've seen the price of insulin triple. Not because of new costs to produce it, because there aren't any, but simply because insulin manufacturers like making more money, and nobody can stop them from jacking up costs whenever they want to. Or most frustratingly, think about the relationship between primary care and hospitals. Primary care is things like checkups, basic medications, the kind of familiar, intimate health care you get from your family doctor, your GP, your PCP, whatever. It's high volume, it's low margin, and generally, primary care isn't super profitable. But now conversely, a hospital gets paid an average of $2,000 a night for an inpatient stay. So if you're a hospital CEO, it makes a lot more sense to push folks into inpatient care instead of wasting your time and minimizing your profit by letting people get cheap primary care outside the hospital. Or it makes even more sense to buy up all the cheap primary care clinics and either close them down or use them to charge hospital rates, which is what they do. That means that 58 million Americans have no access whatsoever to primary care. As you can see, these are the two fundamental but opposing truths to American healthcare. One, if you're an insurance company, it's just not profitable to insure people who are sick. Two, if you're a provider, like a big corporate hospital, it is extremely profitable to charge sick people as much as you can, as often as you can. And so we've built upon these jagged rocks the loathsome church of American healthcare, in which the question of who gets to receive healthcare and when, or rather, whose suffering matters to us, is rationed by profitability. Now, this whole scenario scares the bejesus out of everybody involved, particularly the insurers. Insurers are interested in finding ways to avoid paying rising costs. Often it means refusing to pay for claims that they don't want to pay. It's probably happened to you. But that by itself is not enough to claw costs down. So we all got together, everybody in America, back in the 70s, and invented the idea of consumer-driven healthcare. It's the idea that you should make consumers, which is just a libertarian way of saying people, pay more for the costs of their own health care. We are told this will make us into smart shoppers somehow, true actors in the free market who will make smarter and less expensive choices about our health care. We will Yelp our surgeons, for example, which is why your deductibles and co-pays increase every year, to make sure you put more of your own skin in the game. It's a big load of horseshit. All this does is help insurance companies pay out fewer claims, because people who are forced to pay for healthcare costs they can't afford just don't seek healthcare. They don't get primary care, preventive care. They don't get their flu shot. Because we demand people bear the burden of healthcare costs they can't afford, they're left to watch their bodies turn into time bombs until they have a heart attack at their job and leave their kids behind. We've decided to punish people with healthcare costs they can't afford under the guise of making healthcare a matter of personal responsibility, all so that healthcare CEOs and their friends can bring home millions and millions of dollars a year. But at the end of the day, costs keep increasing and quality of care stagnates for the most vulnerable among us. Our health finance model takes money from the poor and gives it to the wealthy. It is negatively redistributive. In 2014, it pushed 20 million people into poverty or extreme poverty, and 31 million people are still uninsured. The American model of health has failed. And there are consequences for this failure. Because among so-called developed countries, it is America that is the most dangerous place to be sick. Among peer countries, America is the most dangerous place to be black. Black infants die at twice the rate of white infants. America is the most dangerous place to be pregnant, with the highest maternal mortality rate of any first world country, of which 60% are entirely clinically preventable. America is the most dangerous place to be a child, the most dangerous place to be a woman, the most dangerous place to be gay, the most dangerous place to be old, and one of the most dangerous places to be disabled. This year, life expectancy at birth fell by 1/10 of a year. And across the 4 million people born last year, that's a theft of 400,000 years. But a funny thing happens when you look at the data more closely. When you look at the data more closely, you realize all this danger only exists if you're poor. Because rich people are exempt. They have exempted themselves from these problems. Men born in the wealthiest fifth of Americans get to live 15 years longer than men born in the poorest fifth. Among women, that gap is 10 years. We, America, have made a choice. We have explicitly made a choice. By sustaining our private insurance model, we have chosen to let poor people die from things which spare the rich. We have chosen to let poor children die from things which rich children do not die from, all because our health finance model genuflects towards the pitiless pursuit of private profit. And this is war. This is the terrible secret of American healthcare. This is the fundamental American illness. They are killing us and robbing our corpses to foot the bill. And so this big, stupid, multi-payer, profit-driven Rube Goldberg machine of American healthcare is failing us today, and left unchecked will collapse tomorrow. That is incontrovertible. It will collapse. So we demand something different. We demand a federal, universal, single payer. Hell yeah. Single payer is a pretty simple concept. I spent 15 minutes on private insurance. I can do single payer in one sentence. Here it goes. We pool together all the money we spend on healthcare to cover in full all care for all people. Easy. One sentence. It's called single payer because we create one and only one publicly funded, publicly owned insurer. Now that phrase, all care for all people, is crucial. We don't want Medicare as it exists today. Medicare is cost sharing, private carve-outs, so does Medicaid. We demand an improved Medicare that guarantees comprehensive coverage, including long-term care, for all people in America, including non-citizens, that is free to use. Because everybody benefits when accessing care is easy. Now, delivering care, being a doctor, being a nurse, being a home health aide, that's complicated. The body is a huge bag of unknowable goo, and it hurts all the time, and making it hurt less is a difficult process. But paying for it isn't. Paying for it's pretty simple. People ask, how can we pay for this? We're already paying for it. We're just spending our money really stupidly. America is already spending the money required to fund single payer. We're going to spend $3.9 trillion, 3.9 trundo this year on healthcare costs. Between half and two-thirds of that is direct government spending. The rest is your premiums, deductibles, and copays, the private tax you pay to insurance companies. Of that $3.9 trillion, one-third, one goddamn third, is spent on nothing more than waste. Half of that is payer-side waste, like admin costs and high prices. The other half is provider-side waste, like unnecessary or inefficient care. Now, take single payer. Every study I've found, except for two, claims that single payer will cost less than what we spend now. One recent paper claims that the single payer plans in Congress will cost 10% less than what we're spending now. We could spend 10% less to cover all people in full. Just that large healthcare corporations jack up prices and profits, and insurance companies are unable to do anything about it. They are incompetent, so they take their cut and shovel the costs back upon you. And so our swollen and furious American model of health bleeds and bloats, and it leaves you to suffer. Single payer lets us liberate people from medical costs and reallocate this spending to take care of everybody long term. Part of the reason costs are so high is because private insurers have small customer bases and just can't negotiate with big hospitals. But Medicare for All represents 330 million people, so it can basically set its own fair prices for care because it's the most powerful negotiator around. So these wildly inflated costs get their balloons popped and are brought back down to earth, and we're playing on an even field. But even before that happens, we free up all the money associated with admin costs and profit within the private insurance market. This optimization opens up, in a conservative estimate, an additional $370 billion a year. 370 bundo. That's a big chunk of change. What do you do with it? You reinvest it to improve everybody's standard of living. You build or reopen primary care clinics in rural areas. You fund community health centers in poor neighborhoods. And most importantly, you return the money to the people who do the work. Take, for example, home health aides. Y'all know home health aides? I have a sick parent, sick friend, sick kid. A person can receive care in the hospital, but again, that's $2,000 a night. Some folks can receive care in the comfort and safety of their own homes, right? If you've got a disability, long-term care means you can have agency over your own life and being able to live at home instead of being cooped up in a loveless or even hostile or dangerous nursing home. You need help getting in and out of bed, going to the bathroom, feeding yourself. These visits cost an average of $120 per visit, which is great. Everybody benefits. It's more humane care because home is where you live, home is where your dog lives, where your TV lives, where the internet lives, and you save money. Well, everybody benefits except for home health aides themselves, because for this humane and essential service, the 1.2 million home health aides in America are paid a nationwide average of only $11 an hour. And they're billed at $120 a visit. So we can allocate this money to do what the private market refuses to do, pay fair wages for essential care that helps everyone. Just think about it, right? Who makes a real difference in health outcomes? Is it luxury hospital suites? Is it millionaire or multimillionaire surgeons? Is it $40,000 data packages for nerds to look at? Is it apps? No, of course not. Those are just the folks that get to bill the most. What makes a real difference is extra clinical care or compassionate labor. It's social workers, patient advocates, vaccination counselors, nurses. These are the folks who are chronically unrecognized and undervalued, and they're the primary people who make a difference in long-term population health. These are pretty basic ideas. These are pretty simple demands. We understand the social forces that make folks healthy, and we understand the structural ones that make people sick. But in the multi-payer private model, nobody's investing in long-term health. Nobody's investing in population health. Nobody's investing in compassionate labor or paying these people fairly. And they never will. Because right now, your private insurer only bears the costs of you receiving care while they're insuring you. Because you're going to change insurers in the future, and eventually, God permitting, one day go on Medicare, they feel no pressure to provide you with care that keeps you healthy now or makes you healthier in the future. Let me put it another way. You know that if you're at home and the window breaks, the weather gets in. And if the weather gets in, if it's cold, if there's an ice storm, if it's too hot, you get sick. And if you get sick, or your kid gets sick, you got to go to the doctor. But if the local clinic was shut down or it's booked up, you got to go to the hospital. Now, the hospital's far away, or you don't have a car, you got to take the bus. And if you got to take the bus, or if you got to catch a ride, you got to spend all day dealing with the bus system. If you got to spend all day dealing with the bus, you can't go to work. If you can't go to work, you don't make any money. You don't make any money, you can't afford to fix the window that caused the problem in the first place. And so the answer isn't to fork over a pile of cash every time you go to the hospital. The answer begins with giving people what they need to fix their goddamn windows. But there are no private actors in the American model who will bear responsibility for fixing these problems on their own. The only innovations of the private insurance industry are ones created to solve the problems caused by the private insurance industry. They are incapable of addressing the real and foundational problems of healthcare. They are incapable of fixing the broken windows, of reopening the 18 rural hospitals that have closed in Texas in the past 8 years. They are incapable of repairing the PVC septic tanks in South Carolina that have ruptured and brought hookworm back to the state. They cannot fix this injustice because they've been constructed by and within that injustice. They cannot solve these problems because they existentially cannot conceive them as problems in the first place. But we can, and we do. And so it makes perfect sense that the same actor who suffers when people don't get care should be the actor who pays for that care in the first place. Because once that federal actor, once that single payer bears the costs of providing care and bears the costs of what happens when care is not provided, once we force it to confront the rampant suffering of all its people, it can finally be used as a tool for realizing health justice. If your people are getting sick because they don't have a place to live, or where they live is unsafe, it's full of water, it's full of mold, it's flammable, then housing is healthcare. And you build safe, social housing to bring healthcare costs down. If your people are getting sick because they don't have access to healthy food to eat, and so they're getting diabetes or comorbidities like cardiac failure, then food is healthcare. And you give them affordable or free food options and the time, space, and materials with which to prepare them to bring healthcare costs down. If your people are getting sick because they don't have access to needle exchange programs, therapy, or counseling, then rehabilitation is healthcare. And you build full cycle addiction treatment programs to bring healthcare costs down. Because single payer is not the goal, single payer is only the tool. Health justice, health equity is the goal. And when we fight for health justice, we all fight side by side. Because economic justice is health justice. Environmental justice is health justice. Reproductive justice for those who don't want to reproduce and for those who do, that is health justice. Just wages and just working conditions are health justice. And justice for black lives, justice for brown lives, justice for trans lives, justice for native lives, justice for the lives of immigrants, justice for the well-being of people in prison, and the well-being of all people, regardless of age, gender, race, or creed, that is health justice. Yeah, hell yeah. We have inherited a world in which your permission to receive health care, your permission to be safe in your own goddamn body is dependent upon how much a corporation can extract a profit from you. And thus, we have permitted in our country utter desolation. And I want to talk about the desolation now. Over the course of researching this book, I took to the road. Every morning I'd wake up, eat a banana, drive 6 hours in my 300,000-mile 202 Honda CR-V, give a speech, and then talk to people. People would tell me just the worst things that ever happened to them, which is a blessing, but I kind of became a library of human misery. I want to share 3 stories with you right now. One long, one short, one medium, to contextualize the fight for healthcare and the movement for health justice. The first story takes place in Houston. One thing I haven't discussed much is mental health. And you can't talk about mental health in Houston without talking about Harris County Jail. Now it's the largest quote-unquote provider of mental health services in all of Texas. Which is a fine observation, but reality is a bit more complicated than that. In Houston, people who are arrested and suspected of having mental health issues are held in these dark, dank, dungeon-esque cells in the Harris County Courthouse. You would not know these cells existed unless you were looking for them. So if you're a person with mental illness who's been locked up for a few days for things like trespassing or disorderly conduct, what do? You haven't had your medication while you've been locked up, so you got 2 choices. 1, plead guilty, and you might get out and get home on time served. 2, fight it, and looking at more time locked up without your meds. This is if you're lucky enough to pass as functioning normally. If you're in the middle of a serious episode, things get worse. Then you're held for up to 30 days until the county gives you a session with a psychiatrist. People are held in the hospital wing of the prison or the prison wing of the hospital. There's this concept of the prison-to-hospital pipeline which comes up when you discuss mental illness in jail. But it's not a pipeline. Pipelines go in one direction, usually. It's more like a pinball machine. You got these giant invisible flippers that bounce folks around from jail to hospital, hospital to jail, jail to hospital, hospital to jail, and at some point there's no functional difference between the two. We refuse to care for people, and so they become sick. We make them sick. And if you're the wrong kind of sick, or if you're the wrong kind of person, we delegate your care to private prisons. It's technically not a crime to be poor. It's technically not a crime to be sick. It's technically not a crime to be black or brown, but once you fall into the intersections, the rules change on you. If you're a poor single mother of color, for example, you have virtually no right to privacy. If you're in Section 8 housing, a state agent comes to your apartment twice a month and counts the shoes on your shoe rack. And if they find too many shoes, or if you're a single mother and they find a man's shoes, you can lose your benefits. If you're disabled and in Medicaid, every month a nurse comes to your house to check to see if you're still disabled or if you're faking it. You only get to go through this deeply humiliating process if you're poor enough to qualify for Medicaid in the first place. In some states, you got to make less than $2,000 a year. $2,000 a year. If you're a Medicaid recipient in a work requirement state, every month you got to wait in line for hours in an intentionally understaffed office to prove that you're employed. That's time you can't spend going to work. And so these processes drive people into the hospital or into the streets or into jail. And so long as we use prison to hide those who've been made undesirable by their healthcare needs, healthcare and prison are inseparable. So while the idea that prisons are the largest providers of mental health services in the US is a well-intentioned and technically correct point, it's wrong. Because no prisoner will ever receive the care, support, or help they need to handle whatever's messing with them. And no prisoner will ever be saved from the inevitable return trip once they get out and remain sick and get picked up again. Because prisons are not hospitals. Prisons are warehouses for the mentally ill. Prisons are storage units for the unwanted. That's Houston. Another story I want to tell is about birth and death in Memphis, Tennessee. At the turn of the century, in Memphis, 20 black children died for every 1,000 live births. 20 black children died for every 1,000 live births. That is an incomprehensible number. It is found nowhere else in the first or second world. 20 black children died for every 1,000 live births. Why did they die? Because Memphis is home to 2 nuclear waste disposal sites pushed up against poor black neighborhoods. But it keeps going. These things always keep going. Where do poor babies go when they die? In Memphis, they go to Babyland, which is a corner of the public cemetery. They are put to rest in cramped rows beneath the earth in unmarked graves a block and a half from a Walmart. Or at least they were until recently. Because in 2014, Babyland filled up. Poor black children in Memphis die in such volume. America is killing the poor black children of Memphis by poisoning their mothers and poisoning their homes so effectively that we have run out of room to hide our shame and we have run out of room to bury the bodies. And finally, I want to talk to you about Scott County, Indiana. You might know Scott County is one of the few places in the U.S. with a new population-wide epidemic of HIV/AIDS. We understand the causes. 1, pharma companies invent tamper-resistant opioids, which can't be crushed and snorted. This does nothing to stop misuse, but it's very profitable because you get a new patent. So if you're a person battling addiction, not being able to snort doesn't keep you from using. You just turn to heroin or turn to fentanyl. 2, then Governor Mike Pence shut down needle exchange programs in the state. Needle drugs are illegal, and so therefore they're for criminals, and why should we spend money on criminal health care? 3, Indiana gutted, shut down, or cut funding for community clinics and places like Planned Parenthood. And so here's the breaks. If you're a person in Indiana battling opioid use disorder, tamper-resistant pills mean you turn to needles. Except now you can't find a clean needle because the exchange is shut down, and the clinics you might have gone to for help are unavailable too. So it's predictable. More folks get Hep C or HIV/AIDS. But that's not where the story ends. These people have families. They have communities. And now they have HIV/AIDS, or they've got Hep C, or they're in jail, and their families miss them. These people have been left behind. Now, Indiana also has a very low property tax cap, which limits school funding, and it has a robust school voucher program. And so better off families who didn't want their kids to attend school with the children of users or the children of the left behind sent their kids and therefore their tax dollars elsewhere. And so Scott County schools got less and less money and more kids with families going through the shit. That meant fewer teachers, less food, and no mental health or guidance counseling programs. So the guy who worked there said, you could spot a kid going through hell from a mile away, a kid with a parent locked up, a kid without support, a child unmoored from the world. But there was nothing he could do to help. There was just no funding. There was no funding for breakfast. There was no funding for therapy. There was no funding for daycare. There just weren't any resources to help the children of the left behind. And so Scott County saw an increase in child suicides. All these things have causes. And all these causes are cyclical. They have happened forever. They will continue to happen so long as we tolerate the idea that the body is a commodity. And if that commodity is not valuable, if there is no profit in the care of sick people or homeless people or people battling addiction or people with disabilities or poor people or pregnant people or trans people or women or black people or brown people, then there is always the private prison system ready to receive them for profit. And this servitude continues in death because it is the bodies of the poor that are ripped and sold as transplants to the bodies of the wealthy. There is no end to the body horror of capitalism. There is no line too far for the commodification of the body. I say these awful things not to pornographize suffering, but because these are the stakes of the fight for health justice. And so I want to be explicit. insurance is not enough. Our goal is not simply insurance, but emancipation. We must put the people who have been most harmed at the front of the line. We must walk together every goddamn step of the way. We must never compromise until we all have been liberated. Why is it that some people, oh hell yeah. Why is it that some people have adequate health care and others do not? Why is it that some have adequate safety, adequate housing, adequate food, adequate dignity and humanity while others do not? Why is it that some get to live freely while others are compelled to fear their own bodies? Our health is apportioned to us along the lines of structural poverty and structural racism. Our American body has been poisoned by the wicked snakes of racial and economic and patriarchal domination. And so when we attack, we must attack the beating heart of capitalist exploitation itself. And these are problems private insurance cannot fix, that private insurance will not fix, and that in some cases itself has caused. These are problems which can only be fixed with the full force of all America's people, our bodies together forming the shape of our government, armed with a single-payer healthcare system. Upon our throat is a boot of domination. A single payer offers us a moment of relief upon which we might seize to join together and cast the whole thing off, to dismantle the hateful lottery which permits us basic human safety only to the extent that we are useful to people who make money off our work and money off our bodies. Freedom to organize, freedom to fight back, freedom to escape the structures which bind you, freedom to be safe in your community and your home and your body. This is the future single payer let us march toward. Because single payer is not a revolution. It is a counterattack in the war that is already waged against us, by which subsequent counterattacks are made possible. Now, there is good news. We do know what works. We stand on the shoulders of the labor movement, which has shaped this fight since its inception. We stand on the shoulders of hundreds of thousands of nurses, of tens of thousands of doctors, and the legacy of grassroots campaigns like Adapt and Act Up, who fought against impossible odds and won and won and won again. In San Antonio, movement from paid sick leave turned out 144,000 people, 3 times the number of folks who voted for mayor, making it the largest popular movement in years, if not decades, in that city. In Maine, the Maine People's Alliance turned a minimum wage campaign to a Medicaid expansion campaign and won overwhelmingly at the ballot box. In Idaho, 3 friends bought a Winnebago, painted it green, and drove around the state to build a movement to expand Medicaid. And that movement won 61% of the vote, even as the Dem nominee for governor lost by 22 points. There was no blue wave, it was a mass popular movement. If we give people something material, they will fight to get it. They will fight to keep it. If we fight with people today, they will fight with us tomorrow. We build solidarity so we can build power. I can't tell you what to do in Kansas City because I live in Brooklyn, and nature abhors a carpetbagger. But I reckon our job is not to build a single popular movement. It is to stitch together a popular movement, a big messy quilt of fights for health justice in our factories, in our offices, in our churches, in our dive bars, spanning the country from coast to coast and plains to gulf. And through these kinds of popular, massive mobilizations, and only through these kinds of popular, massive mobilizations, this is a fight we will win. Single payer, Medicare for all, is not a radical proposition among the folks it affects. People like single payer. People like Medicare for all. The more they hear about it, the more they like it. We're simply discussing a basic principle of fairness. And so in closing, I offer you my profession of faith. I believe, beyond any doubt, that single payer is demonstrably sound and eminently feasible. I believe a properly ambitious and well-structured single payer program will do more than any other American social program of this generation to soothe the burns, to resuscitate the spirit, to nourish the moral will of the American people. I believe it will loosen the loathsome manacles of American health finance and its theft of our bodily autonomy. I believe this nation owes its people, whose labor has created its rich banquet, the safety and agency of health care. I believe this healthcare is greater in scope than that which happens upon an operating table. I believe that housing and food and income and more, the basic components of human dignity, are healthcare. And I believe our work is that of striving towards justice for all people, and I therefore believe, I have to believe, that single-payer healthcare is our moral imperative. Single-payer is our tool. Single-payer is our weapon. Single-payer is our first step. But single-payer on its own is not the goal. I have seen, and I know you have seen, such naked suffering inflicted in my American name. I have seen families ripped apart by the unrepentant, unyielding bloodlust of capitalism. I have seen people I love torn limb from limb in the service of extracting profit, and this is intolerable to me. And so I say, enough. Not in my name may this America persist. May we root ourselves not in fear, but in love for those who suffer around us. And from that love, may we cultivate the fury by which this cruel machine can and will be destroyed. My friends, single payer is moral. Single payer is necessary. And single payer is, I swear to you, single payer is achievable. Solidarity now, solidarity forever. Thank you very much.
Thank you, Timothy. So when I told you you could tell he was passionate when he speaks, was I wrong?
Loved it.
We have time for some questions. If you're able to, please make your way down to one of these microphones so everybody in the audience can hear your question as well as the answer.
I will any cue you give me.
Then, can you hear me? Oh, I'm a little close. Hi. My name's Elizabeth Reed. I'm actually from Arlington, Virginia. I'm here for a little while due to my father's death and dealing with all the stuff that happens with that. But when you say single payer, are you talking about Medicare for all, first of all?
Yes.
Okay. So we're not doing a single payer system like ACA and modifying that
No.
and making it better.
Single payer refers to, so the ACA model refers to having a bunch of different payers, insurance companies, Blue Cross, Aetna, Cigna, Medicaid, Medicare. Medicare for all single payers, we have one giant insurer, which is publicly owned, publicly funded.
Right.
It's
So
one-
it'd just be like a model like France or England or like kind of a real universal healthcare.
Yes, ma'am.
The truest universal.
Yes, ma'am.
So how in this political climate where there's so much division right now, how do you feel that we're going to pay for that and we're going to unify? Clearly, it's going to be the Democratic Party mostly on this issue to do this. I mean, it is going to be, we're going to have a lot of doctors. I've had doctors who've told me they're going to quit if this happens. So how do we backfill physicians? And how do we pay for it is really, you're going to disrupt the entire system, which I understand that that's what you want to do. But I don't understand how Elizabeth Warren doesn't quite answer the question, so I'm asking you maybe to answer that question for us. How do you backfill the people who don't want to work under this system? A lot of doctors don't. How are you going to pay for it ultimately? I do like your idea of there's a lot more institutions that need to come under it, but let's just do medicine right now. Just actual medicine and not prison systems and not health, like mental health.
Mm-hmm.
Because
So I heard two questions. How do we want it? How do we pay for it, right?
how we're going to pay for it is really what we're at.
Great, let's do pay for first. Pay for
Okay.
is pretty easy, actually. This is not that complicated of a transformation, right? We already spend enough money to pay for single payer. We spend it's gone up every single year. It was 3.7 2 years ago. It was 3.9 last year. $1 trillion to pay for healthcare. Of that, 2/3 is direct federal spending. 1/3 like direct Medicare, Medicaid, VA payments, or subsidies to private companies, subsidies to your employer to give you insurance.
Sure.
1/3 is out-of-pocket spending that you spend on premiums, deductibles, copays. All we are doing is clumping it all together into one pot and using the efficiency of a single payer to spend less overall. A single payer can spend less per unit. Right now, for MRIs are a good example, right? Right now, one of the reasons costs are so high is because MRIs have wildly inflated prices because you can charge whatever you want and no one can stop you, right? Hospitals can kind of charge arbitrarily high MRI prices. No one can stop them. Once you have a single payer, the single payer can say, we're willing to pay $200 or whatever for an MRI, take it or leave it. And everyone's got to take it because there's no other insurer in town. That's how Medicare works.
But we have so many MRIs in this country, unlike Canada, that they can just leave it and then let people who want to pay for it, because there's a lot of people here in this country who can absolutely pay for concierge medicine. So now we are going into the have and have-nots again. We have tons of MRI machines, like thousands and thousands more than countries like Canada, where their waiting period is 4 to 5 months.
Sure, you're going to have folks that opt out, but there's a whole lot more folks who need, like, the guaranteed, like, you're always going to have places like the Cleveland Clinic that cater to the hyper-wealthy. And while I wish I could, forcibly expropriate their assets, that's not going to be feasible in the next 4 years. But most, like, this is the same argument was made about Medicare or even the NHS. The providers would leave en masse. It did not happen, because one thing providers love more than making money is making guaranteed money. And having guaranteed reimbursement for patients is something that's very, very tempting to a provider.
Are you talking about Medicare?
Pardon?
You're talking about Medicare, not Medicaid?
Yeah.
I'm sorry, I
That's,
didn't hear.
this was an argument made about Medicare back in the 60s as well, is that providers would opt out and choose not to do it. Turns out having guaranteed reimbursement from a payer is extraordinarily tempting, and providers overwhelmingly opt in.
So the ones that normally say, oh, if this happens in the world, it's going to collapse, they actually end up kind of following through.
Yeah, absolutely, they do.
So we're not going to lose as many physicians as we think we are in the end.
No, physicians.
Okay.
There's two things that make this tempting to doctors. One, right now doctors spend literally half their time dealing with billing.
No, they
For nurses, it's 40%. Pardon?
hire people to do that.
Right. And so that's time they can't spend seeing patients or money they got to spend hiring billing people.
Or technology.
Right. Well, the technology isn't great either. Epic is a big load of hooey. That's the best one. Under single payer, you have a one-button model of billing. You know what you're getting reimbursed. There's no Blue Cross Silver tier. There's no Oscar Platinum. There's no Cigna 1035.2, The Rock insurance plan.
Right, but how do you convince
I'm
those
sorry
people
to
with
cut you off, man, but can you finish up with one more question? Because
Right.
we got 5 people behind you
Right,
here.
that is it. This is my last question. How do you get the people with the silver tier, the Cadillac plans, to back away from them?
Here's the easy answer. Nobody likes their insurance company. People love being insured. People hate their insurer. People like being insured. People hate their insurer because your insurers just as soon as you get sick, hit by a car, get a microwave ray hitting the wrong direction, suddenly you're going to face down extraordinary costs. Here's an example. I have incredible insurance because I work for an insurance company. I have the best insurance plan in New York, and I spend $12,000 a year in my health care out of pocket because I'm sick. I'm a sick boy, although I seem very strong on stage. And like I've got it great. I'm young and healthy. Once you got your skin in the game, once you've tasted the bitter apple of healthcare costs, you understand that even the best insurance isn't that good. And everybody has that, or has a friend or a kid or somebody who's on the line. Nobody likes Blue Cross. Nobody likes Aetna. Maybe the CEO does, but the COO, whatever, the CMO. Those guys like Aetna and Blue Cross. No one else does. So we've got a very, very easy unifying force in saying, hey, you're being screwed over by these guys. Wouldn't you like something different? There's this poll that says that this refrain you hear a lot, which is a big load of horse shit, is that folks like single payer, and you tell them that they lose their insurance plan and they don't like it. This elides the fact that you tell them they get to have permanent insurance, and the favorability rating goes right back up. It goes from, I think, one poll said 63, one poll said 53, but generally speaking, folks like the idea of having insurance permanently, because otherwise you're going to change every single year. People don't like having their insurance company. They like having insurance. Let's go to this side.
I want to know how many poor people in Canada, the UK, and Australia who are on these type of plans, how much health care they're getting, including those who are black, brown, and any other color, and those who are poor. I mean, those who are poor. What kind of health care are they getting in those countries? That's my question.
Great. I can't claim to be an expert in Canadian healthcare, although I'd love to go to Canada and check it out. I'm a big fan of Canadian folk singer Stan Rogers. Want to see what he's up to. So I can't give you the particulars of Canadian healthcare. I know they get a lot more than we do here. Canada has a Medicare system. Their drug coverage is pretty poor, and their long-term care model is pretty poor if you got a disability. But you go to the hospital, you get treated regardless of your ability to pay. Right. So wait times in the US are actually worse than they are in Canada. MRI wait times in Boston and LA are, I think, a factor of 2x worse than they are in Australia and Canada. See, here's the thing. For everybody who wants to get an MRI, there's 3 more who can't get an MRI because they don't have insurance. And as Prince reminds us, forever is a mighty long time. Wait times are, so there is some, so what Medicare Australia and the UK have to, sorry, what Canada, Australia, and the UK have to do is prioritize and triage people's care, right? Understand, if a person has a broken leg and is bleeding out, they get to get surgery before somebody who needs a knee replacement, right? That makes sense. Surgery is a constrained commodity. Some healthcare are. So you got to pick who gets things first and second and third. It's based upon urgency and need. And it's a grim calculus, but it has to happen. And so some folks have to wait a little longer than others. But according to OECD ratings, most countries in the OECD, with the exception of the US, don't have wait times which cause massive delays in health. The one exception is orthopedic surgery, like hip replacements, because we have a rapidly aging population which needs more knee replacements than supply was built for 20 years ago when doctors were being trained. That's rapidly shifting. But generally speaking, wait times in the US are just as bad, if not worse, anywhere else. Here, we're rationed by both need and ability to pay, and also race for a lot of the parts. In other countries, healthcare is rationed by need alone, which is much more humane than rationing it by how much money you make. Yes, ma'am.
Timothy, if you're okay with it, I think we'll finish up with these 4, and then we'll sign some books, if that's all right.
Great.
And so I really want you to add that rationing part to your regular presentation. Don't wait for the question and answer part. First off, I love your passion, but I love your sound arguments more. I've seen several single-payer presentations this last year, and no one has really brought this up. We touched on it here, and that is, through single payer, all of those positions that are just paper pushing, code filling, will be freed up to actually give health care. Not that all of those types of people need to be transitioned into healthcare giving, but as an aging society, we need more healthcare providers. Those home healthcare people you were talking about, raising their hourly wage, et cetera, and making it a good job. But that needs to be covered also in this single payer issue, that jobs will be transitioned into something we need more.
Yes. Thinking of a question to answer, but I'm going to go ahead and give a little riff anyway. So the jobs question is great, and here's my answer to that question. Single payer does not remove jobs. A single payer has a requirement to make a whole lot more jobs because there is a massive gap of folks who take care of people. Here's an example of how that happens and how Medicare and Medicaid do a good job of creating jobs that we need and how that can be scaled up. This story takes place in Boston because every now and again a good thing comes out of Boston, and this good thing from Boston is called a medical legal partnership. It's a Medicaid clinic in Roxbury, Boston, which is a segregated part of town, pretty poor, mostly black and brown, really poor health outcomes. And it's a combination medical and legal partnership clinic. So a patient walks in, or this is a real anecdote, a patient walks in, or a person walks in with their 4-year-old kid and says, hey, my kid's having a really hard time breathing. I don't know what to do. There's one social worker behind the desk. Social worker does a comprehensive single intake. In healthcare, you want to have as few folks do your intake as possible so you can get one story, get it comprehensively, move you along. Social worker says, yep, this sounds like a medical issue. Let's bring you one door down and bring in a doctor, bring in a nurse. Oh, your kid has asthma. Okay. Give them albuterol. Here's a prescription. Fantastic. But the social worker knows, oh, hang on a second. Asthma in kids is often caused by living conditions. So what's your home like? What's your apartment like? And the patient says, well, we live in the projects. There's water in the walls. There's mold in the ceiling. And my landlord won't reply to my letters or emails or calls because I'm poor and they don't have to. Turns out they do. You have all these protections against things which make you have all these civic protections against things which make you sick, but you only have access to those protections if you can afford to hire a lawyer or if you have the time or literacy to defend yourself in court on your own, which most people don't. So the social worker says, okay, brings the patient down one more door, and there's a lawyer or even like a law student behind there who says, okay, it's actually legal to have your apartment be in this condition. Here's a letter threatening to sue your landlord. We'll check back in a couple of weeks. What do you know? Bada bing, bada boom, the apartment was taken care of, and the mold was removed. So this social worker represents a really powerful force in healthcare. Right now, if you work in insurance, your job is probably to either work the phones as a nurse or a call center employee, and take somebody who needs health care and find the minimum amount of care you are legally required to give them and kind of push them in that direction, which sucks. That job kind of bites. The social worker has the inverse model of relationship with the patient. Any of y'all know Matthew Lesko? He was on TV in the mid-'90s, late night TV. He wore a big Riddler suit. And his whole John was, there's free money from the government. I didn't get that guy. This dude was very excited to find all the things the government owes you and has to give you so you get your national treasure style check or whatever. That's the model of health finance a single payer is compelled to discover. Hire people like social workers, patient advocates, home health workers, whose job it is to find the kind of care you are legally entitled to have and give it to you such that we preserve long-term population health. Wasn't really a question, wasn't really an answer, but there we go. What's up?
Hi. Are you familiar with Stephen Brill?
Yeah.
Okay, wrote an article, actually the whole issue of Time magazine in 2013. It's called The Bitter Pill. You can look it up. It's a fabulous issue. Okay. There's one piece in that article that I want to bring out, and that is there's a graphic in there that shows that the healthcare industry, I'm talking about the insurance companies, the pharmaceutical companies, the hospitals spend $6.5 billion to lobby our congressmen and our senators. My question to you is, how do you plan to overcome that? Because you give a great presentation, and I would love to see Medicare for All, but how do you overcome that? Because just recently we just passed, Senate and Congress just passed a budget bill and has been signed, and amongst other things, Chuck Schumer actually behind the scenes stopped a surprise medical bill that could have solved some things, but he got it shelved. So a Democrat who you had thought would have helped didn't. And it goes back to $6.5 billion, and this goes back to figures somewhere around 2011, 2012. So extrapolate that to 2020, we got a problem.
So, Chuck Schumer is no friend of the little guy. I'll start with that. The only answer, and it's a hard answer, but there's no easy ones. There's no technical magic to solve this. Is a massive popular movement. The only thing will work is if we reclaim and seize the power that is entitled to us in the Constitution. Whether that means electing new people who will be accountable to us, who will push these things through without compromise. I personally am a very aggressive Bernie Sanders supporter, but it's much more than one office, one person. It's much more than one office, one person. One president alone cannot pass single payer. You need a massive popular movement which demands this thing and will not be sated until it is achieved. So the answer is organize. You have to organize the shit out of your community, your people, yourself. Get your hearts pumping. It's a hard answer and it sucks. It'd be much easier not to have to do that, but that's the only way out. And that's not always the easiest answer to hear, but if not that, why bother? Better things are possible. We just have to demand them loudly and enforce. Stephen, oh hell yeah.
I would
One
change,
thing, really quick.
change the thrust just a little bit. For the
Before
fourth,
one thing before that. One other comment on that last question. One thing on Stephen Brill, he has that book, America's Bitter Pill, which I recommend the first 2/3 of. He does a great job outlining healthcare pre-ACA and why the ACA didn't do a great job, why healthcare.gov collapsed. But his conclusion is that we should give more power to private monopolies like UPMC and let them handle healthcare, which is like Patrick Mahomes grabbing the ball, juking left and right, and running backwards for a safety. Hometown metaphor. The first 2/3 of the book are great. Once you hit the 2/3 mark, throw it into the trash, or cut it off and give it to a friend. But it's certainly worth reading a large portion of. I'm so sorry. Now I want to hear your
no
question.
problem. I'll change the thrust just a bit. For the fourth year, I think, third or fourth year, the life expectancy of the United States as a whole has dropped. I think maybe as much as a year for the last 4 years. Every year it's dropped some, and now this year it's dropped again, 4 years running. Could you discuss that a little bit, the decline of the average age of death and whatnot? Could you talk about that a little bit?
Sure. So there's a couple of factors that are going on. I'm not going to get all of them. I'm sure. Like this question is like up there with like the great philosophical questions of life, and I can't know all of it at the same time. But you got a couple things happening. One, life expectancy is not dropping for one category of people, and that's rich folks. They're doing better than ever. They get to live long. They get to have great lives. They get to live till age 96 or whatever. And they're doing fantastic. It is only like in the it gets worse the poorer you are, but the poorer you are, the shorter you live, and that rate's been accelerating over time. Two, people aged 25 to 44 are dying way sooner than they used to. That's driven by two factors. There's this term, diseases of despair, which I don't really like as a term, but it means basically things that are caused by deindustrialization. If you got no money, got no job, got nothing to do, you get addicted to stuff, you die sooner, you sometimes kill yourself. All these kinds of like horrible things happen at an increasing rate among younger folks who have no safety network and no welfare state in deindustrialized areas. These things combine to cause these problems. At the same time, you've got crumbling infrastructure, especially across the South. Nobody has healthy food to eat or can't afford healthy food to eat. You've got food deserts across massive rural areas, so diabetes is on the rise. Diabetes causes heart failure, a bunch of other stuff. No one's solving that. Apps don't solve food scarcity. You have crumbling infrastructure all over the country, and now we're beginning to feel the consequences of that. And of course, these things don't affect you if you have, I don't know, $200 in the bank or whatever, right? I don't know what it sounds like a lot of money. I don't know what a lot of money is. If you have more than like 6 figs in the bank, these problems don't affect you. If you have more than 5 figs in the bank, these things don't affect you. It's everybody else who has to bear this, and we'll bear it for the rest of our shorter lives. Okay, I think that's the end of the questions. Thank you very much. Oh, just kidding. Oh, I'm so sorry, I didn't see you. You were camouflaged.
Well, I got out of the way so people could see you. Number one, excellent presentation of arguments for universal health.
Thank you.
Number two, clearly you're speaking to the choir for the most part. There may be a few converts here, but it sounds like most of the people that are here are in full agreement with you.
Mm-hmm.
What I would love to have is answers to the two big questions that people always ask me when I address this. One is they will say, well, it can't be done. And you've addressed the politics a little bit, but that's one argument. Can it be done? I think it can, and I think I have reasons, but can you give us points to pass on? And the second question or objection, obstacle, is we can't afford it. Can you give us answers to those questions to help others who aren't believers become believers?
Cool, great questions. On the first one, it can't be done. I don't think I have a great answer. My personal answer is, if it can't be, then why bother trying, right? And I find that an unsatisfactory answer. I try because I believe this thing can be done. I believe there is a potential for a mass movement. I believe I believe things have gotten so bad, the contradictions have been so heightened that single payer is feasible. Folks like it, folks want it. There is a popular movement for it. Like it exists. It is ours to seize if we dare. And I don't have a great way to win folks over into that view. But if there's a certain fatalism which is more easily dismissed once one is part of a organization or part of a larger effort, right? This is not a thing I prepared. Let me think this through. There's this idea that's been kind of circulated over the past 30 years, my entire life at least, that individualism is the highest point of expression. Expressing oneself by oneself on one's own terms for oneself as oneself is the ideal of what it is to be an American. That in America, you haul yourself up by your bootstraps. You are an iceberg. You are solitary. You are individual. And through that idea, yes, nothing good is possible. Nothing can be won if we are 330 individuals marching in different directions all at the same time. And that's this idea that we are all our own little drummer boys going in our own little directions is makes you feel atomized and isolated and lonely and unable to do things. I find comfort in organizing with others. I'm not really an organizer. I'm an activist. I just yell a lot. But I like showing up. I like canvassing with people. I like going to marches. I like texting for Bernie, which is something I can do at work, like at smoke breaks and stuff. Don't smoke. But if you do, use your break text for candidates you like. I like these things. These things make me feel like part of a movement. And I believe, because I am part of that movement, that these things can be won. So I guess the answer roundabout of how do you convince folks that these things can be won is bring them to a meeting where folks also think things be won and get part of a broader, like, don't despair, organize, right? That's the cliche I like. 2, how do we pay for it? My easy answer is we're already paying for it. Single payer saves money. It doesn't get simpler than that. Zaza Gabor would say, it's simple, darling. I'm going to use her terms. We spend 3.9 trillion. Single payer costs 3.6 trillion, I believe. Like, we're already spending the money. We're just changing around in like the Excel columns where the money comes from and where it goes. But we certainly can't afford it. We're already affording it. We're wasting money not doing it. We can afford more and better care and spend less money doing it. It's simple, darling. Okay, I think that's it.